First on our agenda today are Dr. Ann Lucky and Jen Phillips, who will be talking about nutrition in EB.
Good morning. Thank you all for actually coming. I hope you all had a good time at the aquarium last night. And what I would like to do today, we have half an hour to talk about nutrition, and I know this is a really important topic. Let me introduce myself. I'm Dr. Ann Lucky, and I'm the co-director of the Cincinnati Children's EB Center. And Jen Phillips is the nutritionist who is a wonderful nutritionist who is dedicated and become very expert in nutrition in EB. So we will each just talk briefly for about 10 minutes. I'll talk about the causes of malnutrition in EB and some of the consequences, and then just tell you what you really want to hear, which is what some of the strategies that we have that hopefully will be helpful to you in battling some of the nutritional problems. And so for many of you who deal with this day in and day out, I apologize, you probably know more about this than I do, but I thought I would give a brief overview of why a skin disease, epidermolysis bullosa, should have such a focus on nutrition. And the causes of poor nutrition primarily are decreased intake of calories, and I'm going to talk quite a bit about that, but also increased use of calories and the increased metabolic needs. Many of our patients have wounds and chronic inflammation. This takes extra energy for wound healing, and also often have chronic infection, which again take extra energy. What are the causes of decreased intake of food? Well, as many of you also know, limited mouth opening is a problem. And as our patients get older, especially in recessive dystrophic EB, it's hard to get a toothbrush in, keep teeth clean. Because of the small mouth, teeth become crowded and they're very prone to tooth decay. So it is difficult sometimes to eat. In addition, the lining of the mouth is very fragile, and they may be very easy blisters or raw areas, or we call erosions in the mouth, again, making it very difficult to eat. The second cause is that swallowing may be very difficult, and this is first of all because of mouth pain, if there are blisters at the back of the throat, but also the esophagus. The upper third of the esophagus, also in recessive dystrophic EB, has collagen 7, which is the same protein that's missing in the skin, and is very prone to getting blisters and erosions and eventually strictures. And the arrow there shows you a very typical photograph of what, when you may have had, or your children may have had a barium swallow, what it would look like, that the barium goes down, then it gets stuck in a little narrow spot and comes out again. And the strictures and webs, these are the little things that we're talking about. And Dr. Ziskan is going to talk to you about this in more detail this afternoon. I thought I'd just mention a little bit about some of the behavioral and psychological factors that I think are very important for nutrition. In terms of vitamin D, our patients have a much less than average exposure to ultraviolet light because they're bandaged most of the time, and some of them are in the house a lot and not out. And not that as a dermatologist I advocate anyone going out and go sunbathing. We do have, all of us get a certain amount of vitamin D just from being out and about and having our arms and legs in the sun from time to time. Decreased physical activity and can be a predisposing to things like osteoporosis. And then as our children get a little bit older and into the teenage years, I think many of you will have found or may find that aversion to taking food and aversion to using their G-tubes becomes a tremendous issue. And lastly, in a minority of patients, but I think it's still a problem that families need to be aware of, pain becomes an issue, and use or overuse of pain medication or in some of our teenagers, unfortunately, substance abuse with various drugs decreases appetite. And we had one particular patient, we really worked very, very hard to try and figure out why he just wouldn't gain weight until we discovered that actually he was addicted to multiple street drugs. And that was the cause of his poor nutrition. So having a background of pain often is predisposing. In addition, as I mentioned, using a G-tube is problematic for some families. And eating is problematic because some children have very little control over their lives. They have to get bathed by their parents. Everything has to be done for them, but eating is something that they can control. So I think many of you may find that meal times often become, which is normal between parents and children, a hassle of who's going to make the decision about what's eating. And I can't emphasize enough how important it is to be open to getting psychological counseling, to getting help in some of these issues that come up over the behavior. Now, what are the consequences of poor nutrition? Well, there are a lot of things that happen when you don't have adequate nutrition. You get poor linear growth, delayed sexual maturation, constipation, and I'm going to talk about that a little bit more, anemia, thin bones, osteopenia, which is relatively thin, and osteoporosis, which is high risk for fractures, cardiomyopathy, which is a weakness of the heart muscles, and of course we know poor wound healing. So how do we monitor nutrition in EB? Probably classically we follow the height and weight curves, but we have found that declines and changes just using the height and weight curves can be very subtle, and that linear growth, which is the acceleration of height, is often preserved really until the absolute threshold of malnutrition is reached. And we have found, and it's something you may ask your pediatricians or your doctors about, is that looking at basal metabolic index provides a much more dramatic representation of nutritional health. And I can show you here in two examples of someone who up to age 8, where the blue arrow is, see if I can find that, my little arrow here, there was gradual decline in growth in weight, and growth was getting a little bit smaller. But if you look over here at the BMI curve, you could see there was a really, really dramatic, and what is BMI? It's a measurement of the relative weight to height. So as your weight gets lower and lower to your height, your BMI will go down. And you could see at this point where the arrow is, there was a critical level, and it was at that point that a G-tube was placed and adequate nutrition was provided, and you can see there was a dramatic improvement. So in retrospect, we might have at age 7, and at that time we didn't look at our BMI, we might have gone back at age 7 and say, you know, maybe we should think about a G-tube before we really get into nutritional problems. And here's another example. If you look at the growth, the linear growth has been very good, and it was just a little bit of a fall off in weight, but there was a dramatic fall off in BMI. So it's a good indication about when to start thinking about it. And this is just what we said, that the BMI are much more dramatic and good for predicting.